Hi, and welcome to this revision video on thalassemia. It's aimed at haematology registrars, and I made it primarily for my own revision. It will cover the pathophysiology of alpha and beta thalassemia, the diagnostic investigations, and how to treat it in a clinic setting, and what to do in pregnancy. So let's go back to basics. There's 3 types of hemoglobin in normal adult blood. The majority is hemoglobin A, which is 2 alpha chains and 2 beta chains. Then there are minor hemoglobins, hemoglobin A2, which is 2 alpha and 2 delta, and hemoglobin F, which is fetal hemoglobin, which is 2 gamma and 2 alpha chains. Hemoglobin A with the 2 alpha and 2 beta chains is expressed at a low level in early fetal life, but the main switch to adult hemoglobin occurs around 3 to 6 months after birth, when the synthesis of the gamma chain is replaced by a beta chain. So what is thalassemia? There's a reduced rate of synthesis of normal alpha in alpha thalassemia or normal beta globin chains in beta thalassemia, resulting in unpaired chains that precipitate and contribute to ineffective production of red cells. The more unpaired chains there are, the worse the syndrome. Clinically, the main syndromes are transfusion-dependent thalassemia major or non-transfusion-dependent thalassemia, with moderate degree of anemia due to a variety of genetic defects. Alpha thalassemia, these are caused by alpha globin gene deletions. The clinical severity is related to the number of the 4 alpha globin genes that are missing or inactive. Loss of all 4 of the genes completely suppresses the alpha chain synthesis, and because alpha chain is essential in fetal as well as adult life, this is incompatible with life and leads to death in utero, hydrops fetalis. 3 alpha gene deletion leads to a moderately severe hemoglobin around 70 to 110, microcytic hyperchromic anemia with splenomegaly. This is known as hemoglobin H disease because hemoglobin H, which is a tetramer of beta globin chains, can be detected in the red cells of these patients by electrophoresis or in reticulocyte preparations. The alpha thalassemia traits are caused by a loss of 1 or 2 genes and are not usually associated with anemia. The MCV is low and the red cell count is over 5.5. And hemoglobin electrophoresis is normal, and DNA analysis is needed to be certain of the diagnosis. In beta thalassemia, there's more of a spectrum, with either no beta chains being produced or small amounts of beta chains are synthesized, and the excess unpaired alpha chains precipitate in the erythroblast and in mature red cells, causing severe ineffective erythropoiesis and hemolysis. The greater the alpha chain excess, the more severe the anemia. So the productions of gamma chains also help to mop up the excess alpha chains and ameliorate the condition. So the patient will have a majority of fetal hemoglobin, and unlike alpha thalassemia, the majority of the genetic lesions are point mutations rather than gene deletions. So as you can see, it's all about a balance. The worse the ratio is between the alpha and beta globin chain synthesis, the worse the syndrome of anemia. As you can see, thalassemia major or intermediate have more severe anemia as there are more unpaired alpha chains. The red cells that enter circulation contain a varying amount of free alpha globin, which increases with the phenotypic severity of beta thalassemia. The alpha globin and its breakdown products are damaging to the red cell membrane, causing it to become more rigid and resulting in a shortened red cell survival. In hemoglobin H disease, on the other side, hemoglobin H is a tetramer of beta globin chains which have a very high affinity for oxygen, so that also contributes to anemia and the need for transfusion. So looking more in detail of the pathophysiology of beta thalassemia, starts with a mutation causing a reduction of the beta globin chain. The extent of the reduction determines if the thalassemia is intermediate or major. If the ratio of imbalance is severe, then the excess unpaired alpha chains pair with more gamma chains, making fetal hemoglobin, or it precipitates out into erythroblasts, causing degradation and faulty red cells and causing hemolysis. Fetal hemoglobin also has a higher affinity for oxygen, which leads to hypoxia and the upregulation of erythropoietin, causing bone marrow expansion. Hemolysis and ineffective erythropoiesis contributes to anemia and splenomegaly. The more severe it is, the more likely the patient will need regular transfusions. Erythroblasts also secrete molecules that reduce hepcidin synthesis, so that leads to more iron absorption. So thalassemia is an iron-loading anemia. This excess is exacerbated by transfusions, and the iron excess can lead to endocrine dysfunction, liver cirrhosis, and cardiac failure. So the patient eventually needs iron chelation therapy. So thinking about the lab diagnosis, think about it when your blood film shows severe hyperchromic cells and a microcytic anemia. Sometimes normal blasts are also seen in beta thalassemia, intermediate, and major, and is not really seen in alpha thalassemia, hemoglobin H disease. The ineffective erythropoiesis in the marrow also precipitates as basophilic stippling, which is remnants of RNA, and there might be target cells which indicate hyposplenism. High performance liquid chromatography is also a diagnostic method which identifies the different variants of hemoglobin, especially when more than one type exists together. So the general method is that the hemoglobin is ionized and absorbed into the column, and it's eluted by a means of gradient of increasing ionic strength. And as the elute passes through a photometer, it measures a change in absorbance, and so you get different peaks at different hemoglobin. So in beta thal major, there will be no normal hemoglobin A, but you'll see a small increase in hemoglobin A2, and almost all the hemoglobin will be fetal hemoglobin, which is 2 gamma and 2 alpha chains. So typically the blood film features are marked hyperchromic microcytic anemia. You've got anesopoikilocytosis with target cells indicating hypersplenism, the basophilic stippling again, and polychromasia. The differential diagnosis for this blood film might be iron deficiency anemia, but the degree of anesopoikilocytosis is too severe for isolated iron deficiency. You might think of beta thalassemia intermedia, but these patients tend to have circulating nucleated red blood cells, which are absent in hemoglobin H disease, and the reticulocytosis in hemoglobin H is more prominent. You might think of hereditary pyropoikilocytosis. The cells are normocytic and the hemoglobinization is normal in that condition. You could also get acquired hemoglobin H disease, but you'd have to look for features of dysplasia which may point towards an underlying myelodysplastic syndrome. The clinical features of beta thalassemia major include severe anemia that's apparent around 3 to 6 months after birth, when the gamma chain production switches to beta chain production. The infant presents in the first year of life with failure to thrive, pallor, and a swollen abdomen. Swollen abdomen might be because of splenomegaly, enlarged liver and spleen, and that's from excess red cell destruction, extramedullary hematopoiesis, or iron overload, which happens later on in the pathophysiology. The large spleen increases the red cell requirements by increasing red cell destruction and pooling and causing expansion of the plasma volume. You might also get expansion of the bones because of intense marrow hyperplasia, which leads to thalamic phases and thinning of the cortex of the bones. And that can cause bones to fracture with bossing of the skull. And on an x-ray, you might get a hair end appearance. Iron overload occurs because of hepcidin suppression, because of the ERFE molecules that are secreted from erythroblasts. So patients will need regular transfusions in the first year of life unless the disease is cured by a stem cell transplant. And patients will need treatment with iron chelation therapy. Without that, it can lead to cardiac damage. The patients are prone to infections. Anemia especially predisposes to bacterial infections like pneumococcal, Haemophilus, and meningococcal infections, especially if a splenectomy has been carried out. Yersinia enterolytica occurs in iron-loaded patients being treated with deferoxamine and can cause severe gastroenteritis. Liver disease can also happen from iron overload, and osteoporosis may occur in well-transfused patients. Main goals of treatment is treating anemia and preventing symptoms and morbidity associated with that, such as impaired growth, preventing extramedullary hematopoiesis, which can lead to bone expansion, hypersplenism, and reducing excess iron stores, which is associated with intestinal iron absorption or transfusion. Thalassemia major patients are generally on a chronic transfusion program to prevent symptoms, and many individuals with thalassemia intermedia may eventually need a chronic transfusion therapy, but there might be times like pregnancy or surgery or periods of rapid growth where they may need transfusion support. If patients start developing cardiopulmonary compromise or signs and symptoms of extramedullary hematopoiesis, such as expanding bony masses, pathological fractures, or hypersplenism, you might need to start considering a transfusion program. Like we mentioned before, individuals with thalassemia major, as well as a subset of those with thalassemia intermedia, will eventually develop an iron overload, which can cause organ toxicity and even death. So you should start thinking about iron chelation therapy at the same time that a chronic transfusion program is started, or the ferritin exceeds 1000, or the liver iron concentration exceeds 3 milligrams of iron per gram of derived weight, and after about 20 to 25 units of red cell transfusions. The role of splenectomy may be appropriate if patients have severe anemia and persistent anemia not due to iron deficiency, a dramatic increase in transfusion requirement, so like doubling of the transfusion requirement over the course of a year, growth problems, hypersplenism leading to cytopenias, or symptomatic splenomegaly. So in clinic, the kind of things we need to think about is evaluating symptoms of anemia, bony pain for fractures, and hypersplenism, as well as looking at their iron status. You can do this with ferritin, the specific liver scans to look at the iron weight in grams per dry weight, as well as an echocardiogram looking at cardiac function. You might need to do specialist referrals for liver, endocrine, or cardiac specialities, especially for a T2 weighted MRI prior to pregnancy. Growth measurements need to be done in pediatrics, and preconception planning needs to be done in adults. In pregnancy, thalassemia is associated with an increased risk to both the mother and the baby. In particular, there's issues surrounding cardiomyopathy in the mother due to iron overload and the increased risk of fetal growth restriction. In addition, with around 9 months of little or no chelation, women with thalassemia major may develop new endocrinopathies, in particular diabetes or hypothyroidism or hypoparathyroidism due to increasing iron burden. So each visit with the haematology team, there should be a discussion about intentions regarding pregnancy, and that should include screening for end organ damage and optimization of complications prior to embarking on a pregnancy. So in the preconception stage, aggressive chelation of iron is needed to reduce and optimize body iron. And due to safety, all chelation therapy should be regarded as potentially tetragenic in the first trimester. Desferoxamine is the only chelation agent with a body of evidence for use in the second and third trimester. Patients with established diabetes should ideally have a serum fructosamine concentration less than 300 for at least 3 months prior to conception. This is equivalent to an HbA1c of 43. Cardiac arrhythmias are more likely in older patients who've previously had a severe myocardial iron overload. And we use fructosamine to monitor blood glucose levels, as HbA1c is not a reliable marker of glycemic control, as it's diluted by transfused blood and results in underestimation. So we use serum fructosamine as preferred monitoring. Osteoporosis is also a common finding in adults with thalassemia. The pathology is complex, but thought to be due to a variety of factors like thalassemic bone disease, chelation of calcium by chelation drugs, or hypogonadism and vitamin D deficiency. So all women should have vitamin D levels optimized prior to pregnancy and maintained at a normal range. ABO and full blood group genotype and antibody titers should be measured, because alloimmunity occurs in about 16% of individuals with thalassemia, and red cell antibodies may indicate a risk of hemolytic disease of the fetus of the newborn. If antibodies are present, there may be challenges in obtaining suitable blood for transfusion going forward. During pregnancy, the patient should be reviewed monthly up to 28 weeks, and at this point, she needs a cardiac assessment for looking for signs of severe cardiomyopathy with an echocardiogram. Beta thalassemia major, patients may need a regular transfusion, and beta thal intermediate may start to need transfusions if their anemia worsens. That might also be because of other underlying reasons like hemolytic anemia, or you might need to look for other genetic reasons such as an extra alpha gene, which would cause the imbalance of alpha and beta chains to be worse. Thalassemia also contributes to a hypercoagulable state. It's well noted in the literature that thalassemia causes excessive platelet activation. So thromboprophylaxis is needed, and if the patient has been splenectomized, then it's even more appropriate to think about adding in low molecular weight heparin. It's important to screen for red cell antibodies and cross-match in preparation for delivery, and think about an active management of labour to reduce blood loss. Thank you for watching. That concludes the revision video. If you have any comments, please mention them below, and you can contact me on this email and suggest any new topics to cover.